And that really is a requirement for screening for infectious disease. All right, so do I have any questions? Did any of the questions elicit more questions? Or are y'all good? Are you feeling like?
Thanks for going over it. Because that was probably the most stressful test, I think, because it was in front of us, and I was second guessing a lot of it. I did reread the questions multiple times thoroughly, so there wasn't a misreading. It was just like it was just a pause question where I was like, I knew it was one of the two.
Yeah.
I wasn't sure.
So this is why I tell people it's so interesting to me. I think a lot of people have a harder time with open book tests than they do if you just sat and took it. Because if you don't see it, and see, Charlotte, if this isn't the case, because it sounds like Charlotte was looking too for. So sometimes if you have something open book, you never trust yourself. You don't trust your critical thinking ability. You're going to try to find something written verbatim. And if it's not verbatim, you start questioning yourself.
Yeah.
And so I can tell you all that that's so common to do, but have a little bit more faith in yourselves. Try to. All right. Okay. All right, well, I'm glad y'all had a chance to do that. But listen, I don't even know where we stopped. Where did we stop? I think we're talking about urinalysis, right? Maybe.
The renal autoregulation of KUS.
So, glomerular filtration rates?
Yeah.
So when we think about kidney function, and this glomerular filtration rate, we understand that the autonomic nervous system is kind of controlling that, and these hormones are controlling it. So I had told you guys to make sure that you revisited these hormones, right? Because you will be asked about them. You will be asked about where these hormones are from, what they're targeting, and what their functions are. So this talks to you about angiotensin, and then you end up having this causing vasoconstriction, but at the same time telling your hypothalamus that you're thirsty, and usually if we get the signal we're thirsty, we're going to what? Drink. And this can help to raise blood pressure. The vasoconstriction helps to raise blood pressure. The adrenal glands getting a signal to secrete aldosterone to target the kidneys to pull in sodium. Water's going to follow it. All of these things are going to be helping us to raise back up our blood pressure, which is a good thing because, our blood pressure vacillates throughout the day, throughout whatever. And if our blood pressure gets low, a lot of students come in here thinking, oh, anything that raises your blood pressure is bad. No, it isn't. But you can die from seriously low blood pressure. We call it shock, don't we? So you have lots of built-in mechanisms that raise blood pressure back up. So this is one that I like this slide because it really does kind of show those hormones to you. All of them are old friends to you by this time. None of those were new, were they? Right? I like this slide because this slide to me shows a visual. I don't know how many of you all are visual learners, but I feel like I am a visual learner. So I kind of like these things because sometimes they can stick in my head better than even text can. But when you're seeing like blood capillaries and you're seeing the tubular endothelial cells, and there's microvilli for rapid absorption. See microvilli. If this is the tube, so the ducts that we talk about, and we know a lot speaking of train, you can see how some things will go right between the cells and just immediately going back into the bloodstream, right? And being pulled back in. Look how quick some of these electrolytes, all of these electrolytes and water just going straight back in, pulling back in. Some things feel a little bit bigger molecules might not be able to fit through here. So when you think about those, they're going to have to go through the cells of these ducts and then through even the endothelial lining of the capillaries into the bloodstream. So that to me, I can picture that these larger molecules, now this is still an electrolyte, but these larger molecules are going to have to somehow be facilitated, helped, coming back into the bloodstream. So I don't know if I talked to you about renal diabetes. Have I gotten to that point yet? Okay, so here's what I want to tell you about, and you would need to know this. What do you say diabetes means? It just means you're making a lot of urine, right? So you've got excess urine output. But this now, we talked about diabetes insipidus, and that's a disease associated with what hormone? A problem with what hormone? ADH, problem with ADH, antidiuretic hormone. We've talked about diabetes mellitus 1 and 2, right? Insulin dependent, non-insulin dependent. And that was related to what? That was related, we think about the pancreas, right? And we think about insulin and not having enough insulin or not being sensitive to insulin and being resistant to insulin. So that was about glucose, wasn't it? And in diabetes mellitus 1 and 2, we often see hyperglycemia, which would mean what? High what? High glucose in the bloodstream. That's what that would literally mean, hyperglycemia, high glucose in the bloodstream. So if there's a lot of glucose in the bloodstream and that glucose moves through into that filtrate, there's so much glucose here that I don't care how long those ducts are or how long it takes, it won't be reabsorbed because there was so much in there because you had such high blood glucose levels, right? So we said one of the first signs of diabetes mellitus is not just hyperglycemia, it's also going to be glycosuria, which meant what? Glucose in the urine, right? So that all made really good sense, didn't it? Did it? Yeah. This is a review. Did that all make good sense? All right. So, but now, I don't think I started recording. Did I? So I better check it just in case, because I got some. Oh yeah, I did. So I'm recording. Okay, good. I'm fine. So that was a review talking about that. But so what we're seeing right here though is that in that first filtrate at the glomerulus, that first filtrate, you've lost everything in blood plasma, including this good stuff. Look at all this good stuff. You've lost this. You've lost everything except cells and proteins, whole proteins. They can't get through. But all this good stuff has gotten through. So do you need to pull this back in? Most of this good stuff, and you're going to. And let's say you don't have diabetes mellitus. You don't have that. But you have lost glucose, so you've got to pull that glucose back into your bloodstream, don't you? Because we need glucose for aerobic respiration. It's our quickest, cleanest source of fuel. So we've got to pull it back in. And we can, because we inherit these little doorway receptors, these proteins, that glucose will be able to hook up with and be escorted back across to the bloodstream. So again, where do we inherit our recipes for our proteins from? Our parents. And these proteins that on these inner layers of these cells, they're acting like doorways and escorts that are escorting glucose back in. But what would happen if you didn't inherit the recipe for a receptor to pull these back in, or the receptor that you inherited just didn't work quite as well is really what's happening. They just don't work quite as well. Can you pull glucose back in the way that you need to? No, it's called renal diabetes, and it's an inherited disorder. Renal diabetes. So if you can't pull glucose back in time that if you pulled it all back in, it's going to stay in the where? It's going to stay in this filtrate until now this filtrate is at a spot where no reclaiming is happening. And what is glucose? Because it's a pretty big old molecule. It's a pretty big old solid. What is glucose doing to the osmolarity of this filtrate? Increasing it or decreasing it? Increasing the osmolarity. So what will follow glucose? Water. And this is why you're peeing a lot, is because the osmolarity of the urine has changed because of that. It's the same reason you're peeing a lot in diabetes mellitus 1 and 2. But it's also the same reason you're peeing a lot in renal diabetes. In renal diabetes, would you have hyperglycemia? No, why do you say not, Alexis? Well, you are peeing sugar out, but if you didn't have hyperglycemia to start with, So, and now you're losing glucose, in your urine. You actually may have a problem with what?
You're not absorbing glucose back.
Yeah, so you're not absorbing it back in. You're not absorbing it back in. And you do not have hyperglycemia. You do have glycosuria because you can't absorb that glucose back in. Does that make sense? But I like this slide for more than just showing you about these transporters. I just like this slide because you see what's in the filtrate and you see all this good stuff, and you got to bring this stuff back in. Now today, y'all are going to test your urine if you want to. But nobody's going to see it with you, so whatever. So you're going to test it. And you're going to see if you have glucose, and you're going to see what your pH is. You'll even see if you have protein. Should proteins have actually even gone through to the filtrate? They really shouldn't have, but what can happen is if you have certain jobs or if you have certain conditions, you can put strain on your kidneys, and the strain on your kidneys can push protein out through the filters. Would that suggest to you that it's harming your filters a little bit?
Yes.
What do we know about pregnancy? When you are pregnant, good prenatal care requires you every, so often they have prescribed schedules for when you go in to get checked, don't they? And every time you go in, almost before you sign your name, they give you a cup, a golden hand cup. And what are they looking for? Protein. That's what they're looking for. Because if there's protein in the urine, what would it suggest? That there's stress on the what? Stress on the kidneys. And I'll tell you, pregnancy is a wonderful, miraculous time, and it truly is a wonderful, miraculous time. But your blood volume increases by about 30%. That's a significant strain on your kidneys, isn't it? Isn't it, guys? And so they're really watching that. And your kidneys are directly related to your blood pressure. And your kidneys are getting rid of waste products like urea and uric acids and creatinine. And so you're getting rid of these waste products, you're filtering through your kidneys. You want them functioning, because if they're not functioning, this can lead to toxemia. And y'all have all heard of eclampsia and toxemia, haven't you? So anyway, but usually that doesn't happen. But they don't want it to happen, because then is the fetus at risk? Is the mother at risk? Everybody's at risk if that's happening. Yeah, so great. Get that? All right, any questions for me about that? All right, I'm still not exactly sure where we finished the other day, but I think we're okay. Here's what I do need y'all to know, and I think you guys, this is your textbook does a beautiful job. I don't know how many of you are reading it. I appreciate that some of you are, because I see you doing it and looking at it and trying to follow along. It does a beautiful job, really, with explaining all of these processes. So I do encourage people to read as much as they can about this. But they give it to you in a lot of different ways, too. Like these charts, these tables, none of that's new. You've seen all of that in the endocrine system. And are you supposed to have it by this time? But even if you were fuzzy on it, here's another revisiting of it. So please make sure you know it. It will be on the next test. This will all be on the next test. Okay? So make sure you do understand about this. Now, today we said we're going to do your analysis, and we might do this right at the first break, because at the first break, I don't know about y'all, but I need to do that. So, okay. Let me tell you about your analysis, and this is important to know. We know that what's the difference between presumptive diagnosis and definitive diagnosis? And where did diagnosis come from? What's a diagnosis? What is a diagnosis? What's a diagnosis? We say that all the time. But what is it?
No one's wrong.
Yeah, that's pretty much it. That's exactly right. It's like you figured out what's wrong. Okay. So, but wait a minute, what do we use to diagnose? What do we use to diagnose? Y'all do diagnosis all the time. When you get kids or friends or with your friends, whatever, you do diagnosing all the time. What do you use to diagnose? What you see, so assessments of what you can see, what you hear them say, right? Well, if they let you touch them. Okay, so you ask permission before you touch them. But they're telling you things, aren't they? What are they telling you?
Can't read.
They're telling you about their symptoms, aren't they? They're telling you about their symptoms. And signs and symptoms are used for presumptive diagnosis, meaning what you think it might be, what you're kind of going toward, and you're using full assessments if you can. Y'all do it all the time. Don't tell me you don't. And what you're looking for are signs and symptoms. Signs are things you can measure. So somebody can tell you what their temperature is, right? Or you could measure it. Somebody could tell you that their respirations, they just can't breathe, but you could sit and measure them, couldn't you? You could count them. You can listen to somebody's heart, can't you? You can take a blood pressure. Those are signs. Symptoms are what they tell you they feel. I have a headache. How many of you have friends that you get tired of saying that they have a headache? Come on. Nobody in here has one of those friends. Okay. What'd you say?
I'm one of them.
You're one that says you all the time, I'm sorry that you do. But things like that, you can't measure pain. But you're listening to somebody who tells you, I'm nauseous every morning, or I'm nauseous every night, or I just can't eat anymore because I'm nauseous, my stomach hurts. I have a headache. I can't sleep. Whatever. So you use signs and symptoms, and you're getting to a presumptive diagnosis. But where does a definitive diagnosis come from? Definitive means you got the answer. It comes from testing. It comes from testing. It really does. So, laboratory testing. And there's all kinds of testing that you can do. You can test blood, can't you? You can test cerebrospinal fluid. You can test urine. Now look, guys, what has happened, and it's a little bit like what's happening that you all said this morning. You all don't trust yourselves if you have an open book test. You gotta go find it verbatim somewhere, or you kind of don't trust yourselves. What happened in medicine? Because there was this explosion in medicine, which was a good thing on one respect, but another respect, there was so much, and there's still so much being discovered all the time, that clinicians and practitioners kind of had forgotten how to trust their gut instincts about full assessments, and they started relying exclusively on labs. So this is when bedside manner went down, right? Because people were like, I just got to do this. And also litigation went up. So there was a lot of things contributing to it. But definitive diagnosis started to come almost exclusively from the lab, right? So you better know how to interpret those labs. Those lab results are only going to be as good as the person who's interpreting them. So you do have to kind of know this. And when a conversation is had, and this happened back in the late 80s, a conversation is had like, okay, wait a minute. People are ordering way too many labs. How many of you work in like ERs or work in, you know certain practitioners who when somebody comes in, I don't care if they stump their toe, they're ordering the full gamut of everything. Don't you? Do you know that? Do you know what that's doing to our healthcare costs? It's ridiculous what it's doing, right? It's happening, again, for a few reasons. It's happening because of litigation. Everybody wants the right answer, and if they don't get the right answer, they want to sue, and they want to have money for whatever mistake that might be made. That needs to stop. There needs to be some real changes happening. I could tell y'all something, but it's too close, and someone might recognize what I'm talking about, and I wouldn't do that. But I could tell you something that's a story that's just so characteristic of what's going on in medicine right now, where we think people should live forever. And in anything that goes wrong, somebody's looking for somebody to blame for it to go wrong. And that's just wrong too. But anyway, but I want to tell you about lab tests. You all should make a point if you have any kind of dealings in primary care medicine with patients, and nurses are the primary care providers. I don't care what it says on patients' things, the nurses are the executioners. They are. Nurses should have a real obligation to understand when they're looking at labs, to be able to interpret them and understand what's going on with them. In nursing school, you'll get told, oh no, you're not about the diagnosis, you're about nursing care, nursing care, nursing care. So don't tell them that I'm telling you this, but no, you better be doing more too, because you got to check the back of the other people. You do, because you're the one that's the execution. So make a point on this. Urinalysis. I know we talked about CBCs, complete blood counts. Didn't they give us a lot of information? One that also, how much they gave us. Then we had these chem panels, Chem 7, Chem 21 panels. They give you all these chemistries, and they're pretty amazing too, right? But urinalysis gives you the most important and immediate information about the overall health of that patient. So don't discount urinalysis. They're very, very important lab tests, and they can tell you a ton. So be paying attention to that, because if there was one test that can give you the quickest overall account of how that patient is, it's a urinalysis. And I want to tell you all this just in case you don't hear me hear me say this in micro. But a lab test is only, and this should be like censored somewhere, but a lab test is only as good as the specimen that was received. If you got a ridiculous collected specimen, or you didn't put it in the right container, or you didn't store it the way you were supposed to, or you didn't send it the way you were supposed to, the results are invalid. Did you just hear me say that? And that's a truth. That's a truth. So urinalysis are important tests. They can give you a ton of information. The ones that are being done in a medical facility, it's going to be more than 15 different parameters that you're going to get. You're going to get osmolarity for sure. You're going to get pH. You're going to get all kinds of chemical analysis. You'll get whether there's white cells there. Should there be white cells in the urine? No, you'll get whether there's red cells, and even light red cells. So you'll even get that. You'll get whether there's ketone bodies. If there's ketone bodies, what would that suggest? Ketoacidosis. That means it's something's throwing their pH off, and it's because they're burning fats for energy. Now, can we burn fats for energy? Yeah. Sure, we can. And that's okay if somebody tells you that person's been dieting or something. But if they haven't, and they've been under stress and they're burning fats, can that be a whole different ballgame? And you should not have a whole bunch of them. Should you have protein? No. Should you have glucose? No. Should not have those things in your urine. So lots of different chemical parameters from the top. And here's what I tell my primary care providers, my nurses. You guys are allowed to do the top analysis of your urine. How many of you do those? You're not allowed to do the fun, microscopic part, but you're allowed to do the top part. And at the University of Virginia, when we would go around and look in the ERs and all the wards and wherever, most people weren't doing them correctly. They've never been trained to do them, and they weren't reading them correctly. And what did I just tell you? That's very important information. It can be really important for the overall health of the patient, to assess the overall health of the patient. So don't discount your analysis, and make sure that you know how to run it. I want to tell you this. If you think about what urine should look like, there's a C rule we talk about: clear, colorless, and copious. That's how your urine should look. It should be when I say urine that's just leaving the body, so it's still kind of at room temperature. At body temperature. It's not at room temperature yet. It should be clear. Once it starts to cool down, it can become a little cloudy. That can just be normal. But when it's first left the body and it's still body temperature, it should be clear. It should really be colorless. A little bit of yellow is fine because of these waste products. They can look that way. But it shouldn't be dark, because if it's dark, it would suggest osmolarity is high. It would suggest that specific gravity is suggesting that the person's dehydrated. And is dehydration a problem? Yes. So you want to have a lot. If people want to be needing to urinate frequently, I need to go talking about it. And people need to, it should be clear, colorless. So that means you're well hydrated, right? How you collect the specimen for analysis is also important, especially if you think a person is going to have a urine culture. So if a person's going to have a urine culture, they've got to have a sterile setup, right? And if they don't know how to get a midstream clean patch urine, then you should help them, suggest to help them. You should suggest to them how important it is that they get that specimen, because if they don't, and depending on where you are, the next thing is that you might have to do an in and out catheter to get that specimen for them. And if you've done a straight path in and out catheter on somebody, you understand that you're shoving, that's an invasive procedure, where you're shoving the microbes that live on their skin into their blood, through the urethra into their blood. So they may not have a urinary tract infection today, but in about 10 days, what do they have? They're back in your ER, and now they do have the urinary tract infection, and your procedure contributed to it. So if you can avoid that, you should. So you should explain to them what a clean catch means. You should explain to them what a midstream means and how to perform it. A midstream means you start to urinate, you never stop, and then after a couple of seconds, you interrupt it. You don't stop and then start again. You interrupt it. Yes, there's going to be urine on the outside of the cup. Yes, it might be urine on their hands. It's their urine. You know, some people get all freaked out about that. They cannot do that. They cannot get a specimen like that. If they have any problem, though, tell them how important it is, and it might prevent them from having to do a straight path. So a good specimen, and we know, listen to this part, because this is crazy, but we know this, it's in the literature. Lots of studies have been done. An accurate midstream clean catch is as good a specimen as a straight catheter specimen. So if you can prevent somebody from having that, you really should, by taking a minute to explain how important it is to get a good set. Women have a lot harder time getting these specimens, and men, why?
There's a lot going on down there.
There's a lot going on down there. Men would suggest there's a lot going on down there, too.
But they can see it.
It's just different about it, and they can see it, and it's just completely different, isn't it? So men actually have, if you think about the opening of the urethra, male urethra, that is the same normal flora as what's on somebody's skin. Those microbes that's on somebody's skin are very different microorganisms that are in post-pubescent women at the opening of their urethra. They're very different microorganisms. So it's a very different ball. And you're right, men have a lot easier time getting a midstream clear catch specimen. Women have a more difficult time. Just the stance that you have to get it in, right? So think about it. And I've had patients who say that, they're horrified and think that they have to touch their labia, So you should be spreading the labia after cleaning it very well. And keep it spread, right? Start the flow. Don't stop. Interrupt the flow and get that. So why do you have to do midstream? Why is that important? Because there's normal microbes in the opening of the urethra. So the first 1 to 2 seconds, you flush those away. You flush those out. And now you're catching, what hopefully is your sterile body fluid. It is. It's a sterile body fluid. It is a sterile body fluid. It only becomes contaminated when it picks up the periurethral microbes. There should not be any microbes in urine. There should not be. Urine is filtered blood plasma. Is blood considered a sterile body fluid? Well, blood plasma is what urine is. It's filtered blood plasma. So it should be a sterile body fluid. Any questions for me? So how many of you work with babies in your ER? So baggies. You can do a clean catch, and you can put the little baggies on. They know that if you do a proper clean catch, girl, female or male.
I've never done it.
Yeah, so because a lot of times, other states do. What you said? It's hard. They don't say it's So if you've got these little baggies with adhesive around them, so if you do a good clean patch and you can get a good seal, that specimen is as good as an in and out as long as they urinate in 30 minutes. If they haven't, you have to pull it off, do another clean patch, and do it again. But if that could save them from getting an in and out gap, it's worth it for your time as a health professional. The problem is usually a lot of times when you're getting on pre-trained babies, when they're trying to get those baggy urine samples, a lot of times kids they have fever. So if your temperature's raised, are you usually making a lot of urine? So it can take a long time to get a urine sample, and changing it every 30 minutes. The health professionals just don't want to do it. So you know what they do? They cath them. And you know what happens then? They get a UTI from the cath procedure. They do. And because that's trauma to the urethra. It really is. But it's protocol. It's protocol because of litigation. It's that 1 in 1,000 that you might have missed, a urinary tract infection, that they're preventing somebody suing about. Anyway, so these are the things that you look at even before you do the chemical analysis. You're going to smell urine. Can the urine smell tell you anything? I mean, you might not be wanting to smell it, but you smell it anyway. And if you do smell it, what can it tell you? What can urine smell tell you?
Do you feel bacteria or something infection?
You can, because many of the microbes that cause urinary tract infection reduce nitrates to nitrites, and you can smell it. You can smell an infected urine. You can also smell fruity urine. What would that suggest? That there's glucose in the urine. You can smell sometimes from different diets. And y'all, how many of you know like asparagus and other things? Yeah. Sometimes from colors of the urine, can you tell that the person's on certain meds? Yeah. It's important for you all as practitioners too. If somebody's on a med and it's going to change the color of their urine, you make sure you tell them that that's going to happen, because that can be really scary for them if they weren't told that their urine's now going to be fluorescent and glow in the dark. So they prevent a phone call back to you later. So you look at that. It used to be back in the day that practitioners would taste urine. That's not required of you any longer. But they did. People did that back in the day. They would taste their patients' urines to see about a diagnosis. That was way above the Call of Duty.
What's an asparagus to make your urine?
I don't know what that is. I don't know what it is. I've never even, I mean, I know it does it, but I've never looked to see what the chemical is that makes that. Another thing, if urine is really frothy, when it's, now I'm not talking about men who have a long distance between them and the toilet. I'm not talking about that kind of frothy. I'm talking about it when it's just passed, if there's a lot of foam in urine. That indicates protein, and that could indicate problems with obvious problems with the kidneys and filters. Should we? And by the way, I need for y'all to know, sometimes I've seen urine come in that is clear and colorless, but it can have a lot of blood. Blood is not always apparent, but if it is visible to your naked eyes, that's a problem. Yeah, and if you do see pus in urine, is that a problem? What is pus? White blood cells. It's enough of them, it's enough white blood cells together that you can actually see it looks white. So yeah, that's a problem if there's that. And so you want to make sure that you want to make sure you're looking at the urine and you're doing an evaluation of that. This is why those of you who've gotten lab reports, you get that on your report, don't you? It tells you whether it's clear, colorless. It tells you all about it, and you get that. So pay attention to it. And also pH range. It's the one fluid that pH range can be huge. And this is normal. It can be really acidic or it can be very alkaline. And that's normal. It's the one fluid, body fluid, that's okay, acceptable range. Actually, what you'd like for urine to be is acidic. You'd like to see your patients have acidic urine. If they do have acidic urine, it's going to discourage any microbial growth, because is there an opening to the urinary tract? Obviously. The urethral opening. So that means that there's a way that microbes can actually enter. But if you're frequently urinating and your urine is slightly acidic, will that discourage ascending urinary tract infections? What do I mean when I say ascending urinary tract infections, which most are ascending? What does that mean? They start at that opening of the urethra and they move up. The microbes move up. If the urethra is inflamed, what do we call that? Urethritis. If the bladder is inflamed, what do we call that? Cystitis. If the ureters are inflamed, ureteritis. If the kidneys are inflamed, nephritis. Right? So we understand that it's dangerous when it's ascended to the kidneys. Why? Is that more dangerous than urethritis? Why? Because that's filtering your blood. And so now those microbes are very close to entering your blood, your bloodstream. And what do we call actively growing microbes in the bloodstream? We call it sepsis, exactly. And this is a life-threatening event even with medical treatment. Depending on the microorganism, you can have 50% mortality rate with the best medical treatment. So this is why nephritis is usually going to buy you a ticket to wear in-house IV care. Where just urethritis and cystitis, that's going to buy you an antibiotic, right? And go home and call us later if you don't feel better tomorrow, right? So, but the higher up, all of that good, you all agree with that? So look, depending out in the hospital, you get lots of different parameters. But here, I think I've got like 7 or so. So how many of you want to do your own urine? And it's just going to be you and your urine. So I don't care that, I don't have, obviously, patients aren't going to get cups like this, right? But I don't have the money to buy y'all 20 packs of specimens, and I'm not going to spend them down either. I used to let students spin their urine down, and I would help them read the microscopic, but I realized it was becoming a little bit of an issue when I was finding too much stuff in their urines. Not really, but you know, it's not my business, and you know, whatever. So, so anyway, not a big deal, but y'all are just going to do the top part, which you actually as health professionals are allowed to do, but we're going to do them, and I'm going to give you a little quick tutorial so that you'll know how to do them. So who wants to do their own urine? If you'll want to, when you go to the bathroom, now look, I always tell, please tell your patients this too. How many of you get urine samples and you tell them to either leave it in their bathroom or bring it back to you, and they bring it back to you like this? Because it's so full, right? 2 teaspoons, but people know teaspoons. They might not know 10 cc's or 10 mLs, but they know teaspoons. 2 teaspoons, 10 mLs, right? That's all you need to do in your analysis. That's all you need. So you don't have to fill up a cup, and they don't either. So, so if y'all want to do it, when you come back, just get it to your place and have a paper towel down. And I'm going to, after everybody's back from break that wants to do this, the rest of you can just watch. You're just going to be sitting at your table doing your own little urinalysis and figuring it out, okay? Who wants to do it? Okay, so get a cup if you want to do it. Go get it back. And the rest of you, we'll do this in about 10 minutes, okay? So 10 minutes, people will be back. Is that right? Do I? I don't know. Do I want to have my feet on the table? Yeah. Let's go. So what happens mostly when people do these on the wards, they do them in clinics and ERs, they do, doctors' offices, they can do these, and they're allowed to do these and use them for patient, evaluations. There's some things that people can't do though unless they're licensed to do it. They have to have my license in a lab to do it. That's like the second part of these. Now, the most common thing that happens, people don't even do this sometimes in the labs. Because I've been in labs. These strips, now this only has 7 little parameters that you would be testing on this. But like I said, in the real lab, it would be up to 15. But these strips, there's nowhere on here that it tells you they need to be stored lying like this, not like this. So if they are in your clinic and they were not stored this way, and all of them either come with bottles that light can't get through, or they're screw top, or that have this vacuum kind of thing. If that top's not on tight when you come up to get it, you really have to evaluate whether you throw the whole bottle away, and they can be kind of expensive. The reason that they need to lay like this, if you wouldn't want to store them upright, is because every time you open it up and close it, there's moisture in the air, and there's stuff in the air that are getting in here. These strips, there's a lot of them in here. These strips, if you will notice, the little chemicals that are impregnated in these pads are really close together. Aren't they? Y'all see how close together these little strips, these little pads are on the strip? They're really close together. So if they've been stored this way and opened 1,000 times, maybe even left open, what would the chemicals in the strips be doing?
Changing.
Running down, well, changing because of light and because of moisture, but also potentially running into each other. So it doesn't tell you on here, but that's the way it should be stored, okay? Now, there's always an area, no matter how many pads are on here for chemical analysis, there's always an area for you to hold it with your fingers and to be dipping, right? So I'm going to give you these strips. Let me tell you the next thing that is usually done that you could go right now and find this. And I'm going to do full disclosure here. These are a little out of date. But the things I know about these is they've been stored properly. So I think that this is less of a problem than ones that are in date. Who else needs one? So check to see that the expiration date. Check to see that they've been stored properly. Because what this test does is actually all of these parameters are based on colorimetric endpoints. So what that essentially means to you is that at a certain time, you're going to be looking at the color of the little pad and using that color to tell you how much of a certain thing you have going. Now, some of y'all don't have these papers, and probably actually give you some of you these papers just so you can kind of share them. But these colorimetric endpoints are actually on. They're actually on the bottles. So let me tell you what people will do, and this is a fact. How many of you again say that you've done these tests? How many of you have done your analysis? Raise your hands up high. All right, so look how many people in this room have done your analysis. Let me tell you what they do, and y'all tell me the truth. Tell me the truth, those of you who do this. So I bet they haven't been stored like this, have they? How many of you store them like this? How many of you make sure the tops are tight? How many of you make sure that you close the top immediately after you get them out? And there's no sort of like, okay, I've got to do so-and-so, so I'll just leave it open because I'm busy, because you are busy. So what happens is there's that little thing is, that little colorimetric thing is on the bottle. So what people will often do is they'll dip their stick here, and then they're like this. What's the problem with that? They're all running into each other. Let me tell you what else is a problem with that. And I know that people do this because I've gone by and seen it. They'll think, okay, I'm multitasking because I've got to do this for this patient, but I also need to go give so-and-so something or do whatever. I'll be right back to read it. So they will dip it, put it on the edge of the thing, run through an errand, and come back. If you look at this, you'll see that there's a time sequence here. At 60 seconds, you need to start reading these results. Because if you read them too early, you can get false negatives. But if you read them too late, you can get both false negatives and false positives. So timing is important. Don't go anywhere. Breathe. And watch the clock and do it. Another thing that happens mostly, though, is that people will dip them like this. They'll dip them like this, and they'll wait. And like I said, they'll hold them wrong. What you don't want is you want to tilt the cup and never have this way. You always want to have it horizontally. So you want to dip it, make sure it's really wet, and then you have to blot it. And you don't blot it with the pads down. You blot it with them at a 45-degree angle that's pulling the urine off. If you don't pull the excess urine off, again, you can get cross reactions with these. You look at your clock, and exactly 60 seconds. You don't do this. You do not do that. You look at it this way. And at 60 seconds, you can start reading, and you use the color endpoints as your reactions. So if y'all want me to do your test, that's fine. And I'll get, remember, blot it, and then I will get some spray, a little bit of spray, just because. By the way, urine is a we treat it with universal precaution, right? You're only doing your own urine, so you can't catch something from yourself. You already have it. But what I do want you to do is after you check your urine, I want you to just quick spray the thing off. You can take the urine back into the bathroom if you want to. The urine can really go down sinks. It's the same place, but if you want to do it at the toilet, that's fine, flush it. And then they can just use regular trash. It'll be okay. And I will get some spray for you guys. So check your urine. If you have any questions, let me know. Use the time. Here's where after you take them back to the bathroom. So, okay.
Every urine that comes into the lab for UA is spun down.
Yes, every urine that comes into the lab gets what's called a complete urinalysis, but they don't all get cultures. They do get complete urinalysis, but not all cultures. I've had people who think just because they give a urine sample, it's going to show if they've got drugs, or if they're pregnant, or whatever. And it would just depend on what your strip is. Most of them, for a complete urinalysis, they're not looking for drugs. If it says a drug screen, then they're going to be looking for drugs in the urine. But not all urines get checked for drug screens. So it depends on what you're looking for. Does that make sense?
Absolutely not.
Yeah, they should get a complete urinalysis. So the complete urinalysis means that they're going to take, and usually if you have 10 cc's, it's enough. They're going to pour 10 cc's off, put it in a centrifuge tube, and spin it down. Pour off the supernate, and just look at what's left and the bottom. They can tell so much. You can tell so much from that. You can tell if you have a good specimen or not. Because if you spun it down and you see a lot of squamous cells, and if it's a woman, and you see, let's say you see sperm, and you see squamous cells, and you see clue cells, that means that there was vaginal secretions in the urine. Was that a good sample? Not a good sample. Not a good sample. It's not going to be cultured. If you spin it down, though, and you see white cells and very few squamous cells, which are the cells that are lining, you see very few, and you see white cells, and you might see a few bacteria, then that's going to be a good enough sample to culture. You're keeping especially if it's a clean catch, you're keeping that always sterile in case you need to culture it, right? Sometimes you'll do the culture, but you really probably shouldn't do the culture before the urinalysis because you don't know, but sometimes they do in labs. That's just part of their protocol. They're going to culture the urine and do urinalysis, and then if the urinalysis is bad, they'll throw the culture out because it's going to be worthless.
Now, let me ask you something. Someone acts like they're menstruating, but they will still be accurate.
Well, it would still be accurate if they got a clean catch midstream. If they got a clean catch midstream, it wouldn't have any vaginal secretions in it. You know what I'm saying? But it's really hard as women, isn't it? How many of us have had to give that clean catch midstream? That's hard. And, we don't even want to go into the position, do we? The position you have to get into. It's just tough. It is. It's tough. But it's tougher to have a straight calf. So, yeah. Yeah. Yeah, because how long did it been? How long has it been? If it's been 2 minutes, you can be false positive. That's the one that you're false positive. But it's also, it's more would it to be a sick case? Yes. Yeah, I mean, you would try to want that to be acidic. So this is why they tell you to that you have recurring UTIs, drink mayonnaise, cranberry juice, and this
It's good. It's good to not be surprised by
I have GERD.
Yeah.
So I can't eat. I'm not supposed to eat a lot of stuff.
Yeah, so then, yeah. So anyway, this was water up here, so I don't really have to do this, but those of you who did this, if you take that and then just spray a little bit where your thing was, because we're going to try to use universal precautions. So good. Thank you for playing. Thank you for playing. What you say? This one or this one? But, it's almost all women. If you get any sort of complications in it, it's going to have a little bit of that. And if you go too long in that, you're going to all be false positive.
Yeah, I was looking for image in a minute, and that's kind of like.
It can be false positive on that one. That's the one that will be false positive. Some will go through their positives and then there'll be false negatives.
Yeah.
So that's a problem too. That's why the timing is important. And how many of you would say you know you've done it yourself where you leave it because you think you can multitask, you can run a quick errand and come back and look at it? I know, it happens. That's because people are busy. You know, you do 1,000 different things. Anyway, okay.
Does it have to be zipped right away? Like, if you have a patient come in and say you can just sit right there, you're doing something else, does it have to be zipped right there?
Okay, so that's a great question here. It's a really great question. Urine can be, if it can't be evaluated right then usually what you'd like to do is refrigerate it. But if it's coming from like the floors and the wards, then you would want to do it within like 15, 30 minutes. You really would. There's some specimens that you have to stop everything you're doing and do it right then, like spinal fluid, right? That's got to be attended to immediately. Because within 30 minutes of spinal fluid leaving the body, you've lost most of the microbes in the air. They're not going to. And so that's something you've got to address right then. But urine is one of those that, you know, if you have to refrigerate it, you could do it later. You can do that later. And feel pretty good about the results, really. The reason you want to refrigerate it is because if there is a UTI, those microbes will continue to divide. Then it would throw the quantification off the numbers off. So if they have been in really low numbers, they're going to appear that they're really high numbers when the culture results come back. So you kind of want to halt them where they are as much as you can. You can't help them completely. Body fat. Yeah, maybe have time to do that too.
I got too much on it, so I'm going to do that.
No, wait a minute. You don't get to talk to it. It has to talk to you. Y'all stop talking to it. Okay.
Do you want us to keep these, or
you can just throw them out? You can throw those out now. And here was where you can spray a little bit. So you already did. Thank you. Thank you. This is just all this. Okay, I'm coming. We're going to start back.
Is it the same sheet as the other numbers?
it's a different, no, the sheet had somebody completely different. Okay.
Where did you go?
VCU. Oh, you heard me. Yeah. It took me a minute. You're basic. Shut up. I feel like music.
Okay. All right, guys. So we're back, and so we know urinalysis can be important. Now, as far as like production of urine, usually there's about 1.5 to 2 liters a day of urine for an average size adult with average size, hydration. As far as like they're not dehydrated and they're not overhydrated, it's going to be about 1.5 to 2 liters. You okay? You sure? All right. How much are you?
No, I've been dealing with this for 2 weeks. I'm okay.
Okay. don't let somebody choke in the room in front of you, you know, right? So, scary. So usually 1 to 2 liters a day, that's normal. Poly needs a lot, right? So excess oliguria, this is going to be about a half a liter or less a day. And then urine means you're not making urine anymore. The kidneys aren't filtering. There's no urine being produced at that particular time. So we know what diabetes is, don't we? We know the different kinds of diabetes. We know diabetes insipidus. We know renal diabetes. And we know diabetes mellitus 1 and 2. Gestational diabetes is something that can happen obviously during pregnancy. Gestational, that's what that means, during pregnancy. And people who have gestational diabetes are at a high-risk pregnancy. It's a high-risk pregnancy for the mother, high-risk pregnancy for the fetus, and they're going to be treated like a high-risk pregnancy and hopefully be, educated to what they need to be doing for their own safety and their fetus's safety. And then they actually afterwards are going to usually have may have some problems as well. A lot of times gestational diabetics, they actually resolve after delivery, but not always. Some of them will go into type 2 diabetes and non-insulin dependent diabetes mellitus. And those people who've had gestational diabetes have a much higher risk of developing type 2 diabetes, so they should be aware of that fact. So sometimes being, forewarned is being armed with that. Diuretics, we know a diuretic is going to increase urine output, which means decreasing blood volume, and that means decreasing blood pressure. So is it used for hypertension? Absolutely. That's, kind of common sense, isn't it? If you can decrease the blood volume on somebody, it should decrease their blood pressure. So if they've got high blood pressure, that's one of the first lines of defense. Certainly, if they've got congestive heart failure, which means their heart's not working well, fluid is backing up. It can be backing up around the heart. It can be backing up around the lungs. And so you've got to get rid of that fluid. So giving them diuretics is going to be one of the first lines of defense. How they work is they increase the glomerular filtration rate. More filtrate means more urine being produced. And they're going to, at the same time, decrease all that absorption. We said that we get about 99% of our filtrate gets reabsorbed, doesn't it? But in this case, it's going to decrease that. So there's 2 mechanisms of action here for diuretics, and they serve a great function, diuretics do, in those particular situations. Now, I'm not going to ask you about renal clearance tests, but there are different types. Usually we talk about the creatinine clearance test. Some of you have probably been involved in collecting 24-hour samples out of you. It's incredibly important that you do collect those samples exactly right. You can really, really misinform about your patient if they don't know how to collect it exactly right, how to repeat after you, when you say things, or just make sure you understand how to collect it if they're in-house, if they're a patient in-house and you're collecting it. But what they're usually doing is assessing the blood serum at the same time that they're collecting 24-hour samples to see how much creatinine is being cleared. But this is one of the ways that urologists are going to assess how the kidneys are actually filtering. When we look at this bladder, which is a fluid-filled sac, that's why, we call it cystitis when it's inflamed, is because it is a fluid-filled sac. It's a urine-filled sac, isn't it? It's a muscular sac that's distensible, but is it infinitely distensible, or can it rupture? It can rupture, and that's horrible, and it should never rupture, but it can. Some people actually don't have feeling, so they don't know that their bladder is filling like that, and so they have to cap themselves, right? Or there's a lot of different reasons, but if you have a patient that for whatever reason you think they may not be able to empty their bladder on their own, you have to be keeping up with that and maybe cap them to make sure that you give them some relief with that. I actually, this is true, a pediatrician at UVA was delivering the same time I was delivering my first son. And she was a friend of mine. So she was delivering at the same time. So she worked there, and then she's delivering. Her bladder ruptured during delivery. She'd had like an epidural. I don't think she had a C-section. She had an epidural. And they had just kind of gone too long. And she should have been aware that she hadn't urinated, right? And they needed to make sure they got the urine out. And if they didn't, and her bladder ruptured. She had quite a significant bit of trouble after because of that bladder rupturing. I felt sorry for her. So anyway, when you think about this, the ureters come behind and they enter. They have openings to the ureters here, and then there's the opening to the urethra that, you know, urine's going to move through to exit. These little 3 openings are called this trigon region. When the bladder is empty, it's really wrinkled, and the wrinkles, if you can see those folds, this is called rugae. But anyway, it's supposed to look like that. So then it has the ability to fill, doesn't it, and expand. So you can think of it as like a little wrinkled balloon. And then as it's filling, it has the ability to, and it has the ability to really stretch. Now, when you release urine, and after around the age of 2, you have voluntary control of this. When you release urine, the bladder is actually spasming a little. It's nothing that's hurting you that you can even feel, you even know that that's happening, but it's helping you to empty, completely void the bladder. Some people have spasms of the bladder. When they go to empty the bladder, it will feel like they feel that happening. And those patients will tell you that it's kind of excruciating, the pain of that. Have you ever had patients?
I have a patient who has
spastic bladder.
he has a catheter because of it.
Because it will, because he's incontinent.
Yeah,
So
he is there because of that.
Yeah.
So if the bladder burst, this might be something silly, but it doesn't grow back, does it?
Well, they can try to repair it. They can try to repair it, but you can imagine that there's going to be the bladder's going to be compromised after that.
Was she incontinent after that?
I don't know. I didn't really ask her that. You know.
They have the catheter.
Pardon?
They just put, like, when I was giving birth,
They put a catheter in.
Yeah.
She might have told them not to. You know what I mean? I don't even know what happened. Why she didn't have it.
I just thought that was during the procedure.
Yeah.
Like, they just put a catheter.
Well, yeah. I had natural delivery when I was having Jake and she was having her baby girl. I had natural delivery, but at one point I had a conversation because the labor was so long that I wanted a catheter. And it was interesting because after I had him and I was thinking, and I heard that this had happened to her, I thought, well, that's what I had. Because I was in labor so long and the head was compressing. I knew it was, but I knew that I hadn't urinated in a long time. And I thought, if the bladder is keeping him from coming through, here, let's just get this urine off and release the bladder, right? And I was glad I did after that.
I just thought I had it.
What'd you say?
I just told the nurse.
I was crowning for almost 4 hours. So you can't pee if you're crowning for 4 hours, you know. So I was pushing for 4 hours. So that's the only reason I asked for that. And guess what? I had 2 weeks later a UTI. Yeah. First and only one in my life was that. But it was definitely, well, maybe from that, but I don't know which one. But anyway, so because you know, you cannot possibly, if the head's in a certain position, you can't urinate. Yeah.
Okay, so why exactly is a person incontinent? Is it because they don't have the control?
Incontinent, there are a lot of different things that can lead to incontinence. A lot of different things can lead to that. So one of the things is, you know, the spastic bladder. If somebody has that interstitial, recurring UTIs can lead to that. People who have bladders that, you know, have just gone through a lot, they can have incontinence issues. Some people are incontinent after deliveries, after pregnancy. I don't want any of you that haven't had babies to think that. I have a niece who was told, by this OB that she should have a C-section because she didn't want to have incontinence issues later in life. And she would want sex to be, you know, so she didn't want to have that. She was told that by her OB. So time for a new OB. That's ridiculous. You know, that is like a ridiculous thing. I had 3 huge babies, vaginal records at UVA, my 2 sons. That's true story, by the way. Head records. No, that's true. And their heads were, I forget the actual centimeters of their heads, but Jake was the record, and then 15 months later, Sam's was exactly the same size. So anyway, no, not really, poor thing. I never had a single pain, and I'm not incontinent, and I've never had any incontinent issues, and sex is great after delivery. Young people, don't worry about that. No, I'm just saying. 20 years later, it's not so great, but no, right after. No, y'all, that's way too much information. I was really trying to be funny. I don't need any of that, but I'm just telling you, people shouldn't tell young women that, though, should they? This was my niece's first child, and this is an amazing, miraculous, natural thing. Such a natural occurrence. Vaginal deliveries are natural and should be happening. But when I asked, I was mad, and my sister, who was my coach, so she has her 2 aunts there, we know our noses are flared, and we're thinking, what? You know, so we're there waiting for Jax to be born. And my sister, who was my coach for my 3 deliveries, my kids, and she had 5 boys naturally. Oh, boy. And so we're there waiting to meet Jax, and Jenny is crying because the doctor says she should have a C-section and has told her those things. And we were like, Merle and I looked at each other, we're like, what? You know, and so we got all up in that. We did. We did that all up. No, we were just, I mean, it was just ridiculous. You know what I'm saying? So my only question to the physician, I said, what's your C-section rate? And I'm going to make sure I find out if you tell me something off from that. It was almost 40%. Her C-section rate was 40%. It should be, and a perfect oral C-section rate should be about 6% of deliveries versus 40.
That's awesome.
But that's awesome that she's telling people.
That it's going to. That is ridiculous, isn't it?
I wish someone had told me.
Okay, I want to get back to the incontinence. Y'all help me with the incontinence things. So recurring UTIs that I've known some people who told me that. And I have known some women who tell me after deliveries that when they sneeze or cough, they have some issues. I have had friends who say that they have some issues. You know, what'd you say?
Alzheimer's, dementia.
Oh yeah, so you're not getting the signals right. But there are a lot of different things that can cause incontinence issues, and not just with urinating, but also defecating. So it's spinal stenosis. People can have, and believe it or not, it's not just lumbar stenosis. It can be in the cervical region. That if they have spinal stenosis, it can actually throw off the signals, and so they become incontinent.
Maybe it's like a side effect of medication.
Absolutely, side effects of the medications. A ton of different things can lead to incontinence issues. So anyway, we got this. Now y'all know this is a female urethra, and when we think about the female urethra, it's just really short, isn't it? So in women's, especially post-puberty, women's opening is colonized with normal flora that you need to be healthy. But in that same respect, some of those microorganisms have flagellum, and can they move up the urethra? Yep. And can they cause urethritis and or cystitis? They can. And so this is what becomes kind of the issue. This is why you should urinate frequently, and you should completely void your bladder before you don't just void enough that you're comfortable and go run your tasks. I make it sound like women are the real workers in society, don't I? But anyway, just take your time, urinate completely, because they know that is actually contributes to urinary tract infections in women. Also, bubble baths. Too tight of clothing can lead to urinary tract infections in women. Not urinating after intercourse. Sex should never be traumatic, but and so when I use the word traumatic and trauma, I'm not talking about violence. I'm talking about manipulation. And so sex should never be traumatic, but it's kind of traumatic to this opening, if you think about it, because the vaginal opening is not very far away, is it? So this can be kind of traumatic to this opening, and so you would want to make sure you urinate after intercourse if you are prone to urinary tract infections. What are some other things that you're told? Even pre-puberty, little girls should not be in bubble baths. Little girls should not have lotions put in this area. Little and big girls should never douche ever. right? Not ever. No, that's a terrible practice. Yes.
So like for stuff like someone's eating shit,
Yeah,
like the sprays and stuff like that.
Never should be using those things, ever. They were, I don't know who invented those, but you know, really, vaginal secretions are not supposed to smell like daisies, right? So it's not supposed to be like that. It ruins the balance of your normal flora. So it causes microabrasions of the tissues that are in this area. It can cause drying out, and then even more microabrasions. It messes up the normal flora, so it sets you up for having more potential to actually get infections when you get introduced. You know, we live in a world where we're in a microbial world, so you're going to be introduced to things that can potentially cause disease. But as long as you have normal balance of your flora, they're protecting you from that inoculum. And the inoculum will have to be really, really great to overcome your barriers. But if you're douching, if you're using those things, your barriers are down. It would be just like you opened all your doors and your windows, and you know, you just are wide open for infection. So never should people do that. I had a lady, she's in our nursing home, she's from Germany. I don't know her name, she wouldn't mind telling me who she is. But she was in here, and English was her fourth language. So, because she's German, Russian, French, and then English was a fourth. So I said, you should never douche, you know, never. I think it was in micro we talked about. I said, you should never douche. And she was like, I douche every day. So she was like, I do a very bad German accent. But anyway, I was like, what? Why would you do that? And I was like, you do not. And she said, I do. And so she's telling the whole classes, right? And so I'm just like horrified that somebody would be douching in 20, whatever that was, 2017, I think, a couple of years ago. And I was like, oh my God, do people not know not to do this anymore? And it took us a few seconds. It took us a little while. It seemed like a long time. But I realized that to douche means shower. She showers every day. So, I mean, you should have seen the other students in the classroom. I remember their faces because I'm thinking, you do not do that. You need to stop doing that. She said, what do you mean? That would be disgusting. She said, and I douche every day. Yes, I do. And so I was like, you really do? And so then I'm like asking more questions, and she said, shower. Who doesn't shower? And I was like, oh, shower, dude.
So you had to explain to her?
Yeah, and I said, no, this is different. And she said, oh, no, never. She said, never. And I think she said something like, that's American. She was like, no, we know better than to use. Anyway, but she didn't know that. And I thought, that's how you can really get in trouble. Talking to somebody who's got English as a foreign language. Anyway, did you have a question? Did y'all?
Yeah.
Oh, thank you. Okay, see, that's what I mean. Please ask questions if you don't know. So I have no idea why you can buy all these things over the counter. And some people actually make their own because they think they're doing something that's like whatever. It's terrible. But anyway, you make this, you can buy them. Summer's Eve is like one of the first, I think that was one of the first 50 years ago or whatever. And it was a man who I guess wanted somebody to smell like daisies. I don't know. But you take these solutions and you actually, with a little nozzle, you rinse the vagina. You actually insert it into the vagina and you rinse the vagina out. Look at her looking at me like that. Like I made that up. I didn't make that up. That's actually,
And listen, some people, like Josh's great Nana, she was 99, she's telling me this. She got pregnant because she thought that douching would
clean
not
this
even
out. She thought that was her birth control. It was douching. Well, see,
and then she got pregnant like the first try. She's such a good doctor. She goes, I douched, like I thought it was fine. And that's how she found out douching doesn't work.
Yeah, but
It's not so.
see, well, let me just say this to you guys. That was his who? Who was
That
it?
was his great Nana.
You understand that there was no birth control. There was no birth control. My mother had 8 of us, and she never had any, by the way, never any incontinence issues, and I don't think that other things were probably either. So, but anyway, but Mom had 8 of us, and by the time the eighth, my baby sister was born, there was just starting birth control pills. Were just available. That was in the 60s, early 60s. So that was my mom. There was no birth control. Think about it, if there wasn't birth control.
No.
And so I'd be douching too, probably, right? So if you think, and I'm really opposed to douche. Do you see what I'm saying? But imagine that you have no control of your reproductive health at life. Imagine that you really don't. Can you imagine that? That was not that long ago, guys. Come a long way. We have a long way to go, but it was really a lot has happened in the last 60 years. Antibiotics, immunizations, birth control, being able to have those. We take a lot for granted, I think. But we must remember, I think. So did that answer your question? Yeah, and it's never healthy to do that.
She will look up.
Okay, so that makes me want to tell you something else. True story.
Oh,
This is a true story. I grew up on a farm, tobacco farm, and there were farmers around. And I was little, and I remember this very well. And I know this little girl's, well, she's not little now. She's probably, I don't know, she's got to be 50. But I remember when she was conceived. And I'm going to tell you, it was when birth control became available. And she's about my baby sister's age. But this couple, he's a farmer, she's like whatever. He was very proud that he was going to go get his wife some birth control, right? Because they already had too many mouths to feed. And back in the day, there really wasn't a lot, right? I felt very rich, but we didn't have anything. But anyway, I remember him being so proud, and he talked about it, right? We had this little general store in Scopotown, and he talked about it, and I was little, so I was kind of like just sort of hearing, but not really understanding. But my mom and dad weren't understanding, so they were talking more about it. Anyway, it wasn't a few months later, she's pregnant. His wife's pregnant. And they had gone over to Charlotte Courthouse, and he was so upset because he finally was really taking care of his wife. Do you know what was happening? Do you know why she got pregnant?
Because they didn't have a sugar pills. And she was taking.
I wasn't taking it.
He was taking it.
Oh, that's so sweet.
That is so sweet.
It was, I had chill bumps on my back today thinking of that.
Back in the day, like imagine that was like a controversial thing for him to be like, I'm taking care of it.
I'm taking it. And see, he was so proud that
And
he was taking care of
proud
her.
about it, and then, oh,
That's so sweet.
that's so sweet that he was taking that.
Do you know what the moral of that story is?
Read that.
Yeah.
No, it's that don't assume. What is it, Madeline? Don't assume that people know what you are talking about, and that that they're going to know exactly what to do. Because I still think of them today. I do. I still think of them today. I mean, I was the last. Yes, she was the last one in their family. The last of the
They
siblings.
figured out the
Yeah.
medication.
Yeah, they figured it out after that.
Do you know
And she was precious. I remember when she was born thinking, well, she's precious. She was. Yeah.
Do you know if medicine had any effects on him? Other than
I don't think he was taking it long enough. It would have if he'd done it for a really long time. So, but I don't think he was taking it long enough that it had any sort of effects on him.
It's only been like 2 years for people that might $25, $30. So I was like, my mom couldn't afford it. But insurance didn't cover it.
When I was taking it, it wasn't covered. Guys, it was not covered. So, and it was really a lot. And I remember you gave up something to take that, but you certainly gave that up because you were ready. So really, because wow, I know it's true. And then when it became part of coverage, I mean, why should only the wealthy people have options or have whatever? That's a whole different topic, but an important topic. Such an important topic. So when we think that we haven't come a long way and you get discouraged, don't feel that way. things that, and it things do take time. But anyway. All right, so women, and I want you to know it's E. coli, Escherichia coli that causes most urinary tract infections post-puberty. So post-puberty, it's E. coli. Because E. coli is around everyone's perianal region, right? That's one of the predominant microbes that's in our colons. And we need our E. coli, our Escherichia coli. We need it because it helps us get vitamin K, make vitamin K, and it's part of our digestive process. So there's a lot of it, and it can be cultured around anybody's perianal area, and it's got flagellum. So this microbe can travel. So if people wipe incorrectly, if they wipe back to front, right, or if their clothes are too tight, like thong type things, or if they just don't urinate frequently enough, that E. coli can be here and it can migrate up. So E. coli. Men have urinary tract infections from very different types of microbes. Now I'm talking about men who don't have catheters. Men who have catheters is a whole different ballgame. But men who don't have any sort of other thing, they're going to have urinary tract infections from skin flora like Staphylococcus. Y'all have heard of Staphylococcus, haven't you? That's on everybody's skin, all over our skin, and up our noses, and and what our hands. And so it's usually going to be from Staphylococcus. It can sometimes be from the gram-negatives, but or the E. coli type organisms, but that's usually going to be because men have had Foley catheters in or in and out catheters. Okay, so nutrition is actually urinating. That's what that term for urinating is, and you can see how the feeling that you need to urinate, is perceived, and then people can voluntarily control it. Usually after around the age of 2, usually at least by 4. Sometimes you'll see a little bit later than that. And this is an ancient picture. I have no idea why we don't have newer pictures, but anyway, hemodialysis, where somebody's kidneys are not functioning, so they have a shunt in here that has surgically been put in, and so blood is going to have to be taken out of the body, run through an artificial filter, and then put back into the body after it's filtered. If somebody's on full-time dialysis, it's usually 3 days a week. So they've gotten a little bit better at the procedures to make them more like 4 or 5 hours, but usually the process of getting someplace, getting the dialysis, getting back, it's a whole day event, 3 days a week. Lives change. Some people get approved for home dialysis, but every dialysis event is a potentially life-threatening event. And you can see that. This is you're actually bringing blood out of the body, having to cleanse it, put it back in. There are some patients, has anybody worked in a dialysis unit? There's some patients that you'll hear about in your dialysis units that didn't make it the second dialysis. They threw a clot, they did something, couldn't manage blood pressure, they didn't make it. And then you'll see people who actually have been on full-time dialysis for years, and they go or they do whatever, they've had it, but it's a serious thing. So hemodialysis is what this is. You can also have something called peritoneal dialysis, where they're actually removing fluid from the peritoneal cavity and rinsing out, keeping clear fluid in, and then letting it out. Have you heard of that before? You have, it sounds like.
I just didn't understand what it was.
Yeah, so that's a type of dialysis as well.
It bypasses, like you don't have to shunt it.
Yeah, so no, you don't have, but you usually are going to have an abdominal thing. So they got to go in and they actually put fluid in and then they remove it out. Now,
what's the purpose of having one versus
I have actually, well, hemodialysis is obviously going to be something cleaning the whole blood, but some people have, I don't know if their shunts are just not working or they get to a point they can't have it. Yeah, so anyway, yeah. So you guys make sure you look at the disorders of the urinary system. Y'all know that this is going to be the disorders, and the deeper insights are what you really want to be looking at, right? All right, look, this chapter has so much repeat of what we've already had, but there are a few little things I want to bring your attention to. I'm not telling you this because I don't think you should read it. I think y'all should read every one of these chapters. I think you should start, if you haven't been a reader before or like reading, you should start reading now. You should read from the first word to the last. because seeing that helps you to critically think about something. So do read this because it's going to review the hormones. It's going to review a lot of topics we've talked about, and it'll be good for you to see. But it's very little bit that's new. So I'm going to kind of scan over it for you and give you the new thing and talk about that. But you all should make sure that you spend some time reading it. It usually doesn't take too much time to lecture, and I'm going to try to get through it together. So when we think about our bodies are trillions of cells that are working in communication. They're communicating with each other, aren't they? And our cells are these three-dimensional structures. Some of them are spherical, some of them are flatter, like squamous cells, some of them are cuboidal. But we are trillions of cells, right? And we said our cells are filled with fluid, but our cells are also bathed in fluid. But when we think about that fluid, that water, most of it, and you should know, most of it is inside of our cells. It's intracellular. If you had to really think about that, that would make perfect common sense to you, right? Wouldn't it? Mm-hmm. Okay, but then we do have fluid that's bathing our cells, extracellular fluid. Some of that is tissue fluid, the blood plasma that ends up becoming lymph that's becoming part of this. And then we even have fluids like CSF, don't we? And CSF is mostly water, cerebrospinal fluid. We have synovial fluid. Is that mostly water too? So we have all those other types of fluids that we think about. But most of the water is where? Intracellular. It's inside of our cells. Does water just go inside of our cells and water that's bathing our cells, they stay separate, or is water moving in and out?
In and out.
In and out. Osmosis, right? Osmosis. And water will always move down its gradient. So when we think about osmolarity between these areas, it better be balanced. True? Better be balanced, because that's how water moves. So when I look at this visual, does this make good sense? We're drinking something that might be mostly water. You okay, Nicole?
Yeah.
Okay. We're drinking water. Let's just say we're drinking water. Now, hold up that water bottle. Is that all water, or are there some solids in there? There's some solids, but it's mostly water, right? So we drink that, and because of how water moves, it's going to directly move into our bloodstream. And from our bloodstream, y'all told me at the capillary level, it moves into our tissues, did you say? And it's lymph now. And lymph then moves into the lymphatic vessels, and then that lymph is dumped back into the, dump sounds like such a bad word, but anyway, it's dumped back into the where? Bloodstream. So I can see that. Water's moving. Water's moving. It's always moving. It's never staying still, is it? Moving. It is. It's moving. So how do where do we get water from? Well, we ingest water. We're going to get it from food and drink. They say a lot of times if you think you're overeating, you're usually not really even hungry. You're thirsty, but you're trying to get the water that's in food. That's my problem. All right, but anyway, metabolic water is that we make water when we're getting these chemical reactions inside of ourselves. But anyway, when we think about water loss, we breathe out water, we sweat water, we urinate water, we defecate, and feces is a lot water, isn't it? So we're getting rid of a lot of water a day. If you looked at some of the numbers, it might even be surprising to you how much that you actually kind of get rid of a day. How many of my nurses do intake and output? It's your least favorite thing to do. You've done that, Jessica? So intake, and so that's for your patients. You're measuring everything they take in and everything that's coming out. Those patients are thirsty all the time. All the time. I feel so sorry for those patients. I do. Because can you imagine being thirsty all the time, 24/7? That would be such a hard thing. But anyway, but on average, a healthy adult is going to take in about 2.5 liters a day of food, drink, 2.5 liters a day. And you're going to be putting out about 2.5 liters a day, and it's going to stay balanced. And that's going to mean that your blood pressure is balanced, isn't it? Right? Because this is all related, isn't it? Blood pressure is balanced, which means that blood flow is good, which means that the heart's not having to work too hard. So all of this is all really, really good. Now, look what we're visiting here. Okay, y'all are sick of me talking about hormones. I just hope you got them by this point, right? Because we've seen them a lot. If you're dehydrated, it means that your blood volume's going down, your blood pressure's going down, but your osmolarity is going up because what you've lost is water. You haven't lost solids, have you? So that means the osmolarity is changing. And does that mean that that's going to influence how water's moving through your system? So dehydration is kind of a double whammy. It's a double whammy to your blood pressure, and it's a real double whammy in how water is moving through your system as well. But usually when we become dehydrated, we'll get thirsty. And if we get thirsty, hopefully you're going to be able to do what? And take in some water, right? And hopefully to correct that. So when we think about hypovolemia, low volume in the bloodstream, isn't that right? That's the most common cause of shock is hypovolemia. We had talked about that, hadn't we? And we know that that's the most common cause of shock. And is shock a dangerous thing? Yes, it is. When somebody's blood pressure is really dropping below that systolic level of 90, and it's dropping below that. Not 90. 90 can be kind of normal for some people, but below that systolic level. And it's starting to drop. You better figure out why. So anyway, these are some of the reasons for hypovolemia. And we can see this. What are going to be the effects? Circulatory shock, meaning that the nervous system's not getting blood flow the way that it should. And what controls all homeostasis? The nervous system. So neurological effects are going to be some of the first dysfunctions that you see. And let me say this to you, babies can't manage it. Babies are the most at risk for dehydration. What's the number one cause of death of little kids? Dehydration. And that is the saddest thing you'll ever hear in a sentence, because could it be corrected with just fluids? It could, if it's caught quickly enough. It could be. So this is just showing you pictures of how you lose water, through sweat and through whatever. Can you have too much water? Yeah, and do we know the term edema? Do we know the term edema? Yes, we do. And if your tissues are being pressed with fluids, can they carry out the functions that they need to be carrying out? If your lungs are being compressed with fluids, they can't change shape. What's the only reason air is moving in and out? The changing shape of your lungs, causing the intrapleural pressure to be different from the atmospheric pressure. So that, and also the heart. So all of these things, cerebral edema, certainly is an immediate life-threatening event. It's when there's cerebral edema. So hopefully this kind of makes sense to you too. And again, you're hearing about some of these hormones like aldosterone. This is all new. This is why I make sure I do this chapter, this chart right here. I need y'all to be paying attention to this. How many of you have ever been on those fluid things where they tell you to drink, like, I don't know, some outrageous number of liquid a day, right? Nobody's been on a diet where they've been told to drink like a lot. Let me tell you about fluid intake in a day. Now, this is not in an hour. Nobody should do that. Can somebody dangerously overflood their system? Yes, they can. But if they do it throughout a day, it wouldn't matter if you were drinking 2.5 liters or you were drinking 8. Because guess what the kidneys are going to be able to do? Regulate your blood volume. You're just going to be peeing a lot. And you will be peeing a bunch. So this is why I think this is an amazing chart, because it really shows you that. But here's what I really need you to be paying attention to. I told you that your book tells you 1 to 2 liters a day, right? 2.5 usually being about the normal intake, 2.5. But I want you all to see what happens, and it happens quickly. If somebody gets into this little danger area, what happens to blood volume like incredibly rapidly? The volume goes down. What's happening to blood pressure? It is dropping. And what's happening to the neurological function? It's not working. The neurological function is not working. It's going to be completely off. People will sometimes look like they're drunk, or they won't be able to function, and then a coma is next. So this chart really shows you how quickly someone can get into trouble that's dehydrated. Anyway, so we can actually lose fluid to like bruises too, can't we? So if you're bleeding under the tissue spaces, you've still lost it from your closed vascular system. And you might be seeing a big bruise, and that might look really awful, But sometimes the worst ones are the ones that you don't really even see, that are really, really deep. But there could be enough bleeding in there that you have lost your blood pressure's dropping. You can have, so those are hematomas, we said, hemorrhaging into the tissues, or we call them bruising, but at this point it's worse than that. Pleural effusions. So you'll have patients, that story I was going to tell you, decided not to. It really would be a classic story to tell you all about how people think people should live forever. You know what I mean? Like, she shouldn't have died. She shouldn't have died because, she didn't have, oh, so nothing underlying. Then, in just 2 minutes, found out lifelong cardiovascular disease, kidneys, second kidney transplant. At first, it was perfect, never perfect. It became septic, and it was because of that procedure it became septic. Sepsis is a risk. I don't care what happens, but in any procedure you sign, it's a risk. But this person had cardiovascular disease since infancy, was in her 2 kidney transplants. And I can't tell you how many things that person was dealing with, But anyway, one of them being pleural effusions. So, and they had removed like 3 liters of it. That 3 liters, and I was like, yeah, I've seen that a lot. I've seen patients take it a long time, removing those kind of liters from the lungs. But anyway, a lot more going on than just the sepsis, right? So a lot of different things: respiratory, cardiovascular, renal, a lot, right? Anyway. So electrolytes, do they play a role in how water's moving through our body? What's one of our major ones that plays a role? Well, they all do. They all can. But sodium we think about, don't we? So sodium we think about a lot with that. So, sodium, and usually we don't see people with deficiencies, because do we have sodium in everything? Yeah. So we have sodium in almost everything now. But so we don't usually see that. We have aldosterone that we know causes you to keep sodium in, so water follows it. So we get all this, and we get these hormones. I think that's whatever. So hypernatremia is something that you would see, no kidding. So hypernatremia, and that means you're going to have water retention, hypertension. Does that all make sense? If you've got too much sodium, because one of the things they tell you for hypertension, high blood pressure, is to reduce what in your diet? Sodium. So this is something that y'all have seen, and I hope that kind of makes sense. Hyponatremia, we said, is much less common, but it can happen. So it actually can happen. So anyway, these are some of the values. I don't ask you to learn normal values, but in clinical programs, you do have to learn normal values. So it maybe isn't a bad thing for you to learn. And remember, you also learn units, right? Make sure you know the right units. But I'm not going to ask you that. You might just want to look at it now.
What's the ME?
This is milliequivalents per liter. That stands for milliequivalents per liter. And that's a lot of times how some of these electrolytes are interpreted. Now, potassium, what I do want you to know about potassium, and I don't know why it's not on here, but anyway, or it is Sunday soon. Potassium is one that we know to be one of the most critical when it's non-balanced. So it's potassium. Now, we know aldosterone plays a role, because while it's causing you to pull back in sodium, what will you be losing to the filtrate? Potassium. So it's going to cause, aldosterone is going to cause your potassium levels to, and it's normal for that to happen up to an extent. But if your potassium levels are getting too low, you don't want that happening, do you? Right? So this is going to be when you're looking at imbalances. Now, when you have hyperkalemia, and y'all should know that means high potassium in the bloodstream, or when you have low potassium in the bloodstream, you can get different effects when it's hyper, depending on how quickly it happens. So people who have trauma, that have crush injuries to limbs, or trauma, the cells are getting broken. So what are the cells releasing? Potassium. So this is like a sudden rise, a quick rise that happens. And what is going to happen with that, nerves and muscles are abnormally excited. So what you could get are arrhythmias. And the arrhythmias can lead to cardiac arrest. Those arrhythmias can actually just lead to the heart getting a signal to stop. So if you don't have somebody close by chunky, it's going to be a problem. If it's slow, if the hyperkalemia is slow, it's still a problem with arrhythmias because you're not getting the signals fast enough. So see, hyperkalemia, depending on whether it's a fast onset or slow, what's the risk? Your real risk, mostly to you, is going to be arrhythmias. Hypokalemia, you can sometimes, if it's coming on slowly, you can actually see people sweating. You know, you'll see that their nerve and muscle, they're again going to be less excited, almost like they're drunk. I shouldn't use the word drunk. Give me another one. Because that seems like such a bad connotation. What you say? Disoriented. Thank you. Thank you. Disoriented. So I'm going to try to never use that word again. Just like you shouldn't use the word crazy because that's a very bad word, really. It's a very bad and very, you know, that's a bad word. Nobody should ever use that. So anyway, disoriented. So they're going to be disoriented, and then again can lead to decreased reflexes. So if somebody's done a good neurological head-to-toe assessment, they're going to pick this up. And hopefully they've also listened for a full minute to the heart, and they're seeing that there may be some arrhythmias. And you've got to turn this around if that's the case. Chloride is not as, chloride kind of goes along with the sodium, but what we know it plays the major role in is pH balance. So is pH balance important? Buffers are important. Yeah, so we talked about how important pH balance was. We said we have two major organ systems that whose major functions is to be a buffer, the respiratory system and the urinary system, right? So obviously we understand how important pH is, and chloride is going to play a role in that. We usually don't see as much of a adverse effect if it's out, but anyway, we know it plays that role. Calcium. What did I tell you that calcium could take you out of this world today? And it has nothing to do with your strong teeth and your strong bones. They'll still be strong tonight. But it can take you out of this world because it's necessary for nerve communication. It's necessary for muscle contraction. It's necessary for proper blood clotting. Y'all remember the hemostasis cascade, didn't you? And you remember calcium was in that little cascade in both intrinsic and extrinsic pathways. And you've got to have calcium for proper blood clotting. It plays a role in messenger chemical signaling in the cell as well. So we know what maintains calcium. We know parathyroid hormone, don't we? We know about calcitriol, don't we? We know about calcitonin. Did y'all see? Friends, old friends coming right back here to visit you, right? I had promised you this was a lot repeat, and it really, really is. Hypercalcemia, you will see some situations where you could see hypercalcemia. And you can see, too, that this can lead to cardiac arrhythmias. Again, a very serious kind of thing, isn't it? Decreased reflexes. Hypocalcemia, do you remember tetany? What does tetany mean? Hypocalcemia we talked about a lot in AMP1. What does tetany mean? It's a sustained muscle contraction. And if your muscles are contracting, the larynx is just a muscle. If that starts to contract, what have you closed off? Your airway. So this can lead to suffocation. And so anyway, that's the problem. Now phosphates you think about with buffering, and the weird thing to me, I remember when I was like trying to get all of these electrolytes down, I remember thinking phosphates would be the most important because you've got ATP, ADP, AMP, you've got DNA that has phosphate backbones, you've got RNA that has phosphate. So I was thinking phosphates are so important. Well, guess what? Your body can handle phosphate. So anyway, it's kind of counterintuitive. It does play a role in, obviously it's components of all these things, which sound very important, and they are. It plays a role in pH, but your body can handle imbalances, and so this isn't one that really alerts us. We're going to be incredibly alert to calcium being off, to potassium being off, and even to sodium if that's way off too. So those are the ones that we're really looking at. But pH we said, important. Does everybody remember the scale? Everybody remembers what the scale correlates with? The negative logarithm of concentration of hydrogen ions? Isn't that just fun to say? Okay, maybe not. But we know what it means, don't we? The negative logarithm of the concentration of the hydrogen ion. We know most fluids should fall within this range, don't they? Except for what fluid did we just talk about can have a really broad range.
Sure.
Urine. But most body fluids need to fall within this range. And we know what acids are. There's a lot of hydrogen ions in this, and bases or alkaline substances are going to have less. We know buffers are going to keep you maintained in homeostasis. We know we have whole organ systems, but then we have chemical buffering systems as well. This is an important thing to be maintained. We go through a little of those reactions again. You've already had them. You've already had those reactions. You know about them. This is a crazy slide to me because it says 6.8 is death. They're dead way before then. They just don't know it. So you cannot withstand a pH that's too far off of that normal. I like this visual because you see how if you're really acidic, you've got a lot of hydrogen ions because a low number on the scale means a lot of these pushing potassium out of the cells, right? You see this? Because this is just like ions do what to each other? Repel each other. So now you've got hyperkalemia. And did we say that was a good thing? No, that's a very bad thing. So people in acidosis are having to deal with hyperkalemia, which is affecting their nervous system, which is affecting their heart, isn't it? So that doesn't even sound like that would be a good thing. And it's not. Alkalosis, you can have, again, this can actually be problems here because potassium diffusing in, but the membranes become nerves overstimulated. So spasms, tetany, convulsions. So that can be a problem. You all read through just basic differences between respiratory and metabolic acidosis, and alkalosis, because you will definitely see people in these situations. And that's kind of it. Did you see what I meant about that was all stuff we had? Really? But it's actually kind of nice because they talk about it a little bit slightly differently and just revisit it. So not a bad thing to do. Revisit that.
One question.
Yes, Tim.
What would you do to bring your chloride back in balance? Like say if it was a point off of where it's in normal range. Does that mean it's just not intake enough fluid?
I don't think that anybody really, if it's just chloride that's off, and if it's just that amount off, I wouldn't even pay attention to that result. Hey guys, by the way, you bring up such a good point. You bring up a really good point. Y'all have probably all, even if you haven't seen patients, you've seen your own lab results, right? And you know that the lab flags things that are off. The lab will flag when something's low or something high. Sometimes it's nothing to even think about. So that's one of those things, and that was such a small amount that it's not to think about. You might take a look at the sodium, see how close you were to the sodium, because it usually follows with it. But you know, so some things, just because something's flagged, doesn't always mean that it's even anything for you to worry about. How do you like that for a non-answer? But honestly, chloride, it's one of those that we don't really worry about too much. I would say that what you want to do is look at the sodium and see what the sodium's doing. And if the sodium seems to be too high or whatever, then you might address that. And that should take care of the chloride. You get what I'm saying? Yeah.
So sodium, potassium, and calcium that our bodies cannot really, they can't function.
So the most dangerous electrolyte imbalance is potassium. If I had to pick another one, the next one would be calcium. And then sodium can wreak some havoc too. Yeah, those are good comments and observations. Guys, I'm not going to do any more today, okay? I know y'all, whatever, but for those of you who aren't here that might be listening, okay, I hope we missed you, and I hope you didn't think that you were off today because of Panther Prep Day. The school was advertising that classes were closed, right? Classes were, well, I think the school might have been doing that, but I had told you all that we were here. So anyway, but hopefully we missed you, and hopefully you'll be ready to go on Thursday morning. On Thursday morning, you have 2 quizzes. Thursday morning, you are going to have a comprehensive urinalysis quiz, urine and this water balance chapter, comprehensive quiz. And you're going to have a quiz that I call a gimme quiz. What quiz was that? And we'll count that as a lab because people might want their lab grades to be a little bit boosted. We will count that as a lab where you're going to tell me where the filtrate first happens. Where does it first happen? The glomerulus. And then that filtrate goes into the PCT, proximal convolute tubule, to the loop, to the distal convoluted tubule. Y'all remember this? Is it ringing kind of bell? You're going to list those structures from the distal convoluted tubule to the collecting ducts, the papillary ducts, minor calyx, major calyxes, the area of the renal pelvis, the ureters, the bladder, the urethra, out. You're going to list those structures, right? In order. They have to be in order, by the way, because that means that you kind of know how it's flowing, right? So that's a gimme lab. Everybody going to be good with that? Please, let's get 100s on that, okay? And then you have a comprehensive on those two chapters, the urinary chapter and the water balance chapter. So anything we've talked about in those two chapters, that's Thursday morning. Because Thursday morning, let me tell you what we're going to do after those quizzes. We really are going to get through the digestive system and probably even nutrition, maybe. But here's the thing. I also want us to do the dissections of the rats Thursday. So anyway, we're going to do those. And then you all, next Tuesday, you have a test on the urinary and digestive systems. So yes, 1 week from today. Now next week, we're going to concentrate on reproduction and male, female reproduction. Chapter 29 has a little bit too about senescence, which is normal aging. But anyway, it's male, female reproduction. And then guys, on April the 30th is your final test in here. It's going to be April 30th.
We're not doing it in May.
Right.
You have us for May 2nd with the final exam, and then we didn't mention anything.
Okay, wait.
Thursday.
No, you guys, this has changed. Okay, this has changed. So get your books out and make sure that you know this has changed. I'm sorry, and I apologize for that. I didn't know what was happening at the time. So give you that. No, listen, but it has to change. And so has everybody got their calendar out? So y'all know, you know, it's a compressed this is a compressed session. So I get it. I get that this is a lot of information. But anyway, next Tuesday, which is, I think, the 23rd, you have a test on the urinary and digestive systems. You will also, on that day, have a lab on the digestive, major structures of the digestive system. Of course, we will have talked about every single one of them Thursday. Good?
Yeah.
So that's the 23rd. We are also going to do, and we're going to do our reproductive chapters. They kind of go faster than the other chapters. But anyway, we do those next week. It is on April the 30th. April the 30th that you would have your, it's the first day of exams, but you all will have your final test on the reproductive chapters, male, female reproduction. You will have your final lab that day. Then you will be able to take a break, but you have to start your exam by noon that day on the 30th. And what's the exam going to be? Deeper insights, disorders, and hormones. April 30th. Not really, is it?
We don't have
I think it is Thursday.
I didn't hear that. I'm
We
sorry.
don't have anything on Thursday the 25th. That's reproductive stuff.
Oh, we have, yeah, we're like, yeah.
The
we're like-
25th.
Well, as
Yeah.
far as like tests.
The
Yeah.
25th is after the exam, right?
The exams
I
are the
mean-
third.
The second, okay. I'm good.
Okay. You guys, we're going to finish in this class on April 30th. We're finished in this class on April 30th. Hey, yes, Rayana, we will maybe on the 25th have a lecture quiz. I haven't yet. So those are just kind of gimmies, right? Because you're having to stay up on this. Like today, I'm going to put a discussion board study guide thing. Maybe y'all could do a study guide and use each other. Some of you do the most beautiful study guides I've ever seen. I use your study guides to make questions for the quizzes. I do. No, I really do, because I use them because I think, oh my gosh, yes, I remember. We did talk about that, didn't we? So I'll be able to make a question on it. So we're going to do a study guide discussion. You're going to have your lecture recording up. So do I have any other questions? Do you want me to go through the schedule one more time? Because this is important. We're about to run up on the end of this class. Are y'all noticing that?
Yeah. Could we do like a study guide for like a final? I don't know if anybody else would want to do that.
Or maybe if you don't, like, I think that when they first started talking about Canvas, and I should have mentioned this earlier, they talked about the teachers being able to put in like a group section, like y'all can edit on your classes.
I can make groups.
Yeah, can you make a group section and just allow us to ask questions?
Talk to each other.
Pretty much.
For the final, I feel like that would help a lot, because it's a lot more stuff than the last time.
All right, so that's easy. That's a great suggestion. So that's easy. I'm not going to, let me do a disclaimer. I'm not going to monitor it. So if y'all are spreading misinformation, I'm going to hope that one of you are catching it and letting the others know. But I'm going to create I will create a discussion board area that says just study for final or something. That use this discussion forum for final, final review or whatever.
And how many weeks do we have left? This one? We have 3.
It's not 3 weeks. It's like
this Thursday.
It's like 2 weeks.
Really?
You get 2 weeks until the final exam. Like,
I'm trying to think.
And 2 weeks, but see, you've got 2 weeks to the final exam, but really there are 3 tests left.
Yeah.
So for those people who don't like their test score average, you do have the opportunity here to really better your test average score, which is the predominant score in this class, because it's 2 weeks left.
I'm just trying to think if maybe like this week we could do like one for each test. Do like hormones for this week, and then next week we do one like the deeper insights, and then the next week we do the disorders. Like have it so that it's separate, and that we can just go through it.
So I'm not going to put on there, I'm not going to like close it to people who haven't responded. So it's just going to be open.
Yeah.
So y'all can talk to each other if you want.
So if she
You
doesn't,
can, and I'll even do it so that y'all can put, you can upload files if you want to. So if y'all want to upload,
Yeah. That would be.
it's a great idea. It's a great idea. I'll do it. And it's a great idea. Make sure that you all self-correct, okay? That you self-correct each other if there's any misinformation. Because we're all in it together, aren't we? All in it together. And that's a great suggestion. Are there any other suggestions like that? So you all know that Thursday you have 2 quizzes. A filtrate quiz, which is going to count as a lab, and a very comprehensive lecture quiz on the urinary system and water balance. Thursday we will do the digestive system, and then on next Tuesday you have a test on urinary and digestive and a digestive lab. We will begin on Tuesday male reproduction, and on that Thursday we will probably have a quiz on male reproduction and a lab quiz on male reproduction, maybe even, right? And then on that Thursday, we'll finish up lectures on the reproduction. And then on that Tuesday after that are those finals. The only thing you have to do together as a group is the reproduction test that morning. You have to do that as a group because I want us to go over it as a group. So if you miss anything on the 30th that morning on reproduction, and it was an insight, a disorder, or hormone, you will know why you missed it, and you'll know the right answer. Because on the final that you'll take that same day, just later when you're ready, I'm going to use this room as a testing room, so you can go away and study for an hour or so, and you come back and take it when you're ready. But on that final, might you have some reproduction questions about hormones, disorders, or insights? And if you missed them that morning on the test, I don't want you to miss them again. They might not be worded exactly the same as they were on the mornings, but even if they were, I don't want you to miss them again. You know what I'm saying? So we have to do that reproduction test together so that we can go over it together. And then the room becomes just a testing area that you come and take that final when you're ready. I just ask that people begin it by noon, that you begin your final by noon that day.
So the final lab on the 30th, will that be like the female reproductive organ?
Yes.
Lab?
Yes. These are all really good questions because truly 2 weeks and it's done. Yes, Jaden.
Maybe it was just me, but I thought you said we was going to do a urinary lab with just the 2-3 names on it. Or maybe
No, I was joking. No, I said, wouldn't this be a fun one to do kidneys, bladder? You know, I was kind of joking. I said, this would be a great
I
lab,
was
wouldn't
hoping it was
it? Hey, Jada, thanks. You do have that lab, but it's embedded in the filtrate, right? Because are there kidneys? Do you start with the kidneys? And do you have the ureters? And will you have the bladder in that list? And will you have the urethra in that list? But y'all are going to have more than that, right? But no, I just, do people remember that? Because she's right. I did say, I said, that would be a really great lab, wouldn't it?
But we don't have time, so let's just move on.
I have a question about microbiology.
About micro?
Yes, for the
For summer?
books for summer. Yes.
Yeah.
Is the
Is everybody finished with this? And I'll turn the recorder off. Is everybody finished with this? Miss those of you that weren't here, and I'll see y'all Thursday.